Good morning, everybody. Nice to have you all here, online or physically attending this workshop on phantom motor execution. My name is Corry van der Sluis. I'm from the Netherlands. I'm a doctor in physical medicine and rehabilitation. And this workshop is organized together with Liselotte Hermansson and Cathrine Widehammar, OTs and researchers from Örebro, and Max Ortiz-Catalan, Eva Lendaro, and Maria Munoz. They are all from the CBPR. Phantom motor execution, you already heard something about it told by Max Ortiz, but the goal is to reduce phantom limb pain by promoting the execution of phantom movements by using myoelectric pattern recognition, virtual reality, augmented reality, and serious gaming. And the method we use is projection of the upper or lower limb on a screen and control via electrodes on the stump. Hereby, motor volition is decoded by interpreting the signals from the stump muscles via myoelectric pattern recognition, and the decoded movements are visualized in virtual environments. You see some pictures on the left, and this is what we are going to show and demonstrate in this workshop. The content of the PME treatment is first electrode placement, then movements are selected, the sessions are recorded, and then the actual training starts with virtual reality, the target achievement control or TAC test, augmented reality, and also serious games can be played. All these all this content will be shown in the demonstrations further on in this workshop. The program of the workshop is as follows. We will start with theoretical aspects on the PME treatment by Max Ortiz. Then we will have a demonstration of the system using an able-bodied volunteer, Mirka Buist, because the patient of the lower limb amputation who we had invited could not make it, we heard today. Then we will show a video on phantom motor imagery, which is the control situation we used in the RCT we performed with a lot of international partners. And we will tell something about the research results we have from all the PME studies we have done. And then a second demonstration will be performed. And we are very glad to have Tore Johansson here in the room who will demonstrate his proficiency in the PME treatment. And then there will be, hopefully, some time for discussion and questions. Liselotte Hermansson will be joining us online, and she will help me in chairing this session and also contribute to the presentations. You can see her in the Zoom. So, this is what you will see on the screens and will be explained. The first two steps will be mainly explained by demonstration of the lower limb, and the third steps, the training positions will be demonstrated by Tore, the upper limb patient. So we would like to acknowledge some persons. Christy Turner helped us in preparation of this workshop. The patients, mainly now Tore Johansson. We had some help in arranging the PMI video, and of course we are very grateful for the technical assistance in organizing this workshop. So I hope you enjoy this workshop, and I would like to give the floor to Max Ortiz.
I hope this will not conflict. I'm just going to move this out of the way. Great. Thank you. I'll try to not repeat much of what I presented yesterday, but considering the discussion afterwards, it seemed to me that a few things maybe needed to be clarified. So, if I can get my slides up, great. I guess it is important that we keep in mind the official definition by ISP on phantom limb pain. So it is related to the localization of the pain. And what I mentioned yesterday, and maybe was overlooked a bit, is that there are different causes by which phantom limb pain can be elicited in a person. And then we know that, the difference between nociceptive and neuropathic pain. However, in amputations, by definition, it's both, because there's a neuroma, and that will be considered neuropathic, and the stimulation of nociceptive fibers during that neuroma, will create the experience of pain by, deterministically stimulating it. And for that, there are treatments. So I just want to say that the whole reason about proposing this different definition of phantom limb pain is that we separate neuroma pain from non-nociceptive sources of phantom limb pain. And that is because that's what we're trying to address here. So since the message didn't go through very clearly in my perception yesterday, then I'm just going to break it down on very simple axioms, if you wish. So we know that stimulation of nociceptors of a particular body part, my finger, will create pain normally in my finger. And when limb is amputated, if you stimulate nerve fibers that used to innervate that part of the body, will create sensations in that part of the body. So this is non-controversial. We know about this. And we know that severed nerves have neuromas, and within the neuroma, mechanical stimulation of the neuroma will elicit axon potentials that will stimulate the nociceptive fibers, and therefore, by definition, you will feel phantom limb pain, or by the definition of the ISAP, you will feel phantom limb pain. But this is not the only source. So mechanical stimulation is one, but there can be chemical stimulation, and infections can produce phantom limb pain when they affect the ion channels related to the nociceptors, and then you perceive pain. So the whole point of making this distinction is that we separate this rather non-source of phantom limb pain from, or pain, from what we try to address on phantom limb pain, because what we're looking here, PME is really addressing this other more maladaptive plastic changes. That is the purpose of this therapy. So it's a plasticity-guided therapy will fall into that category. But of course, if there's a neuroma there, it might still produce phantom limb pain every time you mechanically stimulate it. So the main difference between this therapy with others, so there are a few aspects about each of the therapies. And mirror therapy, you can do phantom motor execution with mirror therapy. And the tricky part that is hard to verify it. And if you use virtual reality, despite you can do games and so on, you can still not be certain that the patient is doing an execution of a movement. So the ultimate physiological response to the execution of a movement is a muscular contraction, because for a muscle to contract, the signal has to be generated, calm down, get to the muscle, contract. So by using the activity of the muscles to drive the therapy, we're making sure that the patient is doing motor execution. And that's basically the idea. So you've seen how this works with the upper and the lower limbs. And the first case that we tested this was in a patient who was 73 years old at the time, lived more than half of his life on phantom limb pain. And this color map, it basically shows you the color is the intensity of pain, and then the length of the bars represent the amount of time the patient spent in each level of pain. And as you can see, he had pain most of the time, or around 50% of the time, and 2-3 out of 10%, and then that got less over time. So from there, we did a multi-center clinical trial in 14 upper limb amputees. As I reported before, we found about 50% reduction that lasted for about 6 months, and we saw the reduction in intrusion of activities of daily living and sleep, and there's a correlation between all these metrics. So we measure pain in different ways. And now we're doing a double-blind randomized clinical trial to test the efficacy of this therapy, and we developed few technologies to make it easier to use for lower limbs, and that is possible to use at home, so that we've shown as well. And for that reason, so as I said before, this treatment has been used, and it is used clinically around the world. I think yesterday I said about 100 patients, probably about 200 by now. And a lot of this started as an open source project, and you can identify the lab nature of it. I gave this idea to a company, Integrum, and they produce a product that now is CE mark. I did consultancy on pain for Integrum. I haven't worked. I still consult them on prosthetic stuff, but not on pain since the beginning of this year. So, and then there was when trying to understand why this treatment works, we discussed there are different hypotheses for the origin of pain, and we try to ground the basis for the treatment in one of these hypotheses. And when I tried to do that, I couldn't do it, and therefore I had to come up with one that made sense based on the clinical evidence that was available at the time, and is still congruent with the clinical evidence that is now. So I'm not going to address all of them, just to mention the important ones. Sensory motor incongruence is the hypothesis that is cited in most treatments for phantom limb pain, heavily on vision, despite that the system that's clearly more effective is somatosensation, so tactile and proprioception. As I said before, and you saw in the talk of Dr. Raffin, there's plenty of evidence, and this paper is from 2018, and there was evidence back there to show that the more a patient can move their phantom, the less phantom limb pain they have, which will just contradict this whole idea of the sensory motor incongruence because of the proprioceptive feedback and visual feedback even. And then the temporal characteristics, when is the pain appearing? It's also a problem with this idea. So overall, when we try to explain a phenomena, you look at the evidence, there seems to be more evidence against than in favor of this hypothesis. Now, the other part that it's been thoroughly discussed here is the changes in the cortex. And as I said before, there are mixed results, and even within the same methods, it's not always present in all patients. And then I mentioned this before, we know that the cortex localized pain, stimulation of the cortex rarely elicits pain. And when I was asking the question yesterday about what is the relationship, I was trying to look more about a causal relationship between what's happening in the cortex and the experience of pain. And Professor Floor clarified yesterday that they never claim causality when they found the relationship between cortical reorganization and pain. It was a correlation. So all this to say that if we, and when I posed the question, then there was a question to my talk later on saying like, well, there's some relations between the cerebral cortex and then region A, B, C of the brain. And I guess what I meant is that relation causal? And if it's causal, why are we not studying those relationships that is causal for pain rather than just the mapping of somatosensation for the brain? So all this to say that there's no maladaptive plasticity theory. It's although it has been mentioned in some papers, there is no one paper that says this is the theory of maladaptive plasticity. If anything is an observation, is a fact. Technically speaking, as I said before, maladaptive means something that you really didn't want to happen, and plastic is that it remained. So this is an observation. There's really not a theory or something that explains anything. So as I said before, the phantom motor execution is based on this idea that in a healthy system, even a sporadic activation don't make much of a problem. In an amputation, however, they can cause pain, and therefore, if we get those neural circuitry, again, not talking about the cortex, neural circuitry in general, everything along the neural axis to do its job before, we'll take that away from doing any kind of pain processing. So there's a lot of predictions done by this hypothesis. As I said, you can find those on the paper. We starting to investigate the details of how this happened. As I said before, when the theory of the evolution came out was based on observations. Later on, we found out about DNA, and then we could put all the mechanisms for evolution. But it takes time, and we're exploring the epidemiology. I find very useful to look at the clinical characteristics of pain to validate a lot of the ideas on what works and what doesn't. And then we're looking at mathematical and computational models for pain that are grounded on neurophysiology. So we're spending quite a bit of time on mapping the literature on neurophysiology of pain to be able to start building our models. And then we also done some brain imaging studies. So basically, with all that to say, is that is the reason why the phantom motor execution idea is to engage the neural circuitry that was affected. We use in motor execution primarily because it's easier. It's a top-down approach, so patients can try to execute very complex movements. Sensory, if we will do it the other way with the sensory side, we will need to have high-resolution neural interfaces to create sensory experience that are very rich. When we do it with the motor, we can do it directly from the patient because the patient have control over that. And so it's practical reasons why we went motor rather than sensory. Needless to say, inclusion of the sensory will be good. And this will have as a consequence, for instance, one of the predictions and what we're going to verify with the brain imaging studies. And a good side effect of my electric pattern recognition is that it's not perfect. It's actually quite bad. If you ever tried my electric pattern recognition, it takes a little bit of time to get you to be able to move the hand. So there are certain learning aspects. And that makes the patients to really focus on how they are using their muscles. And when you have conscientious or mindful execution of movement is when plasticity takes place, right? So mindless repetition of movements doesn't cause any change. Because my electric pattern recognition is not a perfect technology that just pick it up as soon as you do it. You have to concentrate when you're trying to do the movements to learn how to do movements. Potentially not even using the natural patterns. I mean, making the claim that the patients are doing exactly the same movement we wouldn't have evidence to support that. Nevertheless, they get to the code. In a transhumeral patient, we've been able to decode 10 movements, for which biologically, anatomically, the biceps, triceps have nothing to do with. So their motor control in the stump becomes better, and that basically engage the motor control circuitry. And as you know, if you learn any activity, we know that pianists and soccer players, they will enlarge their representation of the sensory cortex if you want to look at that as a marker. And that doesn't necessarily cause pain. Actually, that doesn't cause pain. So changes in the cortex by practicing don't lead to pain. Because the argument here will be that the reason is because they're purposely done. And with phantom motor execution promoted with my electric pattern recognition, you're purposely getting the patients to increase the dexterity in the stump muscles. So that's kind of the background of why this is set up the way it is. Just to say that you do not need my electric pattern recognition, as I said before. I think when I'm approached from people in different places and say, like, what can we do if we don't have this system? Mirror therapy done with express intention of movement will be, based on these ideas, more beneficial than just imagining the movement or just visualizing the movement. So if patients are following this, or if you have patients and you don't have equipment to do this, the advice will be like explain, and we hear about, and there is a path of treatment based of explaining pain. That is one area of research in pain, for instance. So explaining some of these ideas and saying, like, if you try to do movements in the mirror and you actually try to execute them and focus on the motor and how will that feel and what you feel in the stump and so on, that will be more useful. So my electric pattern recognition, virtual reality, augmented reality, they are tools to help this therapy. So with that, I wrap up, and then I guess we can take questions at the end. Yeah. Thank you.
So thank you very much, Max. I'm here from Örebro and trying to follow this session. Now we are setting up for a demonstration. This is Maria Munoz and Cathrine Widehammar. who will demonstrate this treatment with a patient with a lower limb amputation. Okay.
Okay. Can you hear
So
me?
I'll leave the floor to you.
Thank you very much. So welcome everyone. My name is Maria Munoz. I'm a physiotherapist and I have been working already 3 years with this technology, thanks to Professor Ortiz-Catalan. So today with my colleague, Cathrine, you can maybe introduce yourself.
Well, I'm an occupational therapist, as Corry said, from Örebro. And I have been part of this project with Max since 2014 and treated patients with this system.
Yeah, so as Corry was explaining before, so we will separate our workshop in 2 sections. First, we will start with lower limb with a healthy participant, and then we are going to go upper limb with a real patient, so to say. So today we are going to do the demonstration with, as Max was explaining, with Neuromotus. The Neuromotus is the CE mark product for phantom motor execution. So we are going to use their device and also their software. So now we are going to start first with our participant. So I will show you in the computer how we start setuping. So when you install the software, you can treat upper and lower limb. And in this moment, we are going to start with arm, with leg, of course, with leg. And yes. So as Corry was explaining before, we have different stages on the treatment. Yes, wait. We have different stages, and also we have different segments that we need to show. So normally you have the device that is connected to a dongle, and the dongle is connected to the computer, and that's how you make the interaction between the device and the computer. So we are going to do the whole demonstration. So the nice part of this is that you can use it with a normal notebook. You don't need to have like a fancy equipment to use it. So that's why actually our aim is to have home use in certain point. So you will just starting by connecting the dongle into your computer. Yes, can you connect it? Yes, and then we also have the device for this system. So in this case, we are going to start with our patient that, as you can see, it will be a transtibial patient. I don't know if you can see here, we have the line. Unfortunately, our participant was not able to come, so we have a different model today. So, well, and before we start showing how to place the electrodes, I will connect the device, because I want to show you that we have different possibilities of training. So, okay. So this is how the software looks, and we will go step by step. But when you start first with your participant, imagine Mirka is a patient, we need to understand also what is the baseline for the patient. Is the patient able to move the phantom? What is the level of the phantom? Of course, we need to know all these variables before starting. So in this main treatment, as Max and Corry was explaining, we want to promote phantom motor execution. So the idea is that we are going to select different movements to mindfully practice this movement in different levels, and we need to keep the patient constantly challenged. So before starting, like you will see that the program will offer multiple options of movement that you are able to train with your participant. So for today, we are going to start with, for example, ankle dorsiflexion and inversion and eversion with our patient. So why we need to know this? Because our electrode placement will be according to which movements we want to train. So we are going to start with electrode placement now. So imagine you have an amputee. So normally, as you may say, like the muscles are not so beautiful sometimes. You see like the surgery, the muscle fibers are in different direction. You not always have a lot of activities. Many of the patients in the beginning refer that actually they cannot move the phantom, or they don't have much muscle activity, which is quite common to see in our patients. So in this case, what we need to do is try to feel and find the muscle activity, so we can use this activity to replicate it in the computer and be able to go to the next steps. So in this case, like, we have our stump. Imagine here we have the line, and we are going to use surface electrodes. For you, if you haven't used surface electrode, there are some principles that we need to know when we place electrodes. So you always need to put the electrodes in direction of the muscle, and of course you cannot put it in the tendons or in the bone, because we really want to get the muscle activity. In theory, we can also not put it in the innervation zone of the muscle, but in practice, you cannot see where is the innervation zone, or that's my experience. So that's why you need to actually pulp and touch and see where you have the muscle activity. Well, Mirka have beautiful muscles, so it's easy to find it in this case. So for example, we pre-select already some muscles, but for example, if you can do up here, you can see clearly her muscle. So we need to put it that we know that the muscle direction of the fiber is this way. So knowing this, like, we need to follow the muscle direction to place the electrode. So because then we want to read the same motor neuron. So can you help me with the electrodes? So I will show you. So normally we use these pre-grilled electrodes, surface electrode. There is no need to be this one. We use biomedical, but of course there are other surface electrodes that we can use for this purpose. And the idea is that are normally disposable electrodes, so we just use it for that session and then we get rid of them. Important part of the story, so the electrode placement is one of the most important part of our treatment, because if we don't have a good electrode placement, then all the recording, it will not work. So if we are not getting a good baseline of recording of our session or our muscle activity, then it's not possible to continue. Another important detail is that our device, so here we have 8 different channels, so it means that we can use these 8 different cables to connect that are bipolar, so we put 2 electrodes per cable or per channel. So that's why we are putting 2 in each of the system. You cannot see? Yes, you can see there. Not the device. Well, in the device, you will see it here. You have certain channels that you must follow to then record the different activities. Important as well, because we have 2 channels of electrodes, 2 electrodes per channel, these 2 electrodes cannot be too distal between each other, because then we are going to read different signals. So ideally, we need to have like 2 centimeters or 1 finger in between these 2 electrodes. One important detail as well, when you place the electrode, in the first session, you try to cover as much as possible, so you place as much electrodes as you can. And then while you know your patient, you can continue and just maybe take pictures or figure out what's the best way to place the electrodes. Yes, so we have here helping with the electrode. Thank you very much. Also, a part of these 8 channels, we have a reference channel that is the ground for our system. So then we avoid to have a different noise or issues with the signal. When we have our different type of patients, so the system allows that we have a lanyard for upper limb, but we also have a band for lower limb. So then it's easy to place the device and the participant can move the limb without any disturbance from the system. So in this case, we are going to use the band to be able to connect here. Thank you very much.
The reference?
Yes. So then we will put we have 7 channels in this case. So yeah, as I explained you before, in the beginning you normally put more channels, so then you can get as much activity as possible. But while you are moving with your patient and you know the activation zone, then you try to use less channels if possible. Yes. Okay. So, in this case, I will show you in the system. So also you can select how many channels you can work with. So in this case, we are going to work with 7 channels, but of course, again, you can decide how many you want. So we are
7.
Yes.
Yeah.
Okay. Okay. So we already, this part is really important to select the movements that we want to train. As we explained before, we need to keep the participant challenging. So in the beginning, you normally start with 1 degree of freedom of movements, but then you do 2 degrees of freedom, and you can also add a simultaneous movement, because the idea is that they mindfully try to perform these different movements and repetitions with a goal. Thank you very much. So you need to select set. Yes. This one is anyway. So the first step is the signals. And in this step, here we see where we place the electrodes with the participant. So you see the different color of the different channels that are connected to the system, so we know exactly where we locate the electrodes. So here we start and we will ask, for example, the patient, can you do first up? Very good. Now down. Excellent. Now in. And now up. So as you may see, like Mirka is doing a strong contraction, but it's a problem to do a strong contraction. Why? Imagine if your patient start the recording session doing the maximal effort, then the rest of the session will be probably fatigue. Normally a session could be 2 hours, so it's quite a lot of time for them to actually put attention, and also if you don't use the muscle contraction or contract your muscle, to ask them to do that. So we normally try to ask them to do like a contraction around 60 to 70% of effort. So can you open it again, please?
The signal?
Yes, please.
Sorry.
No, it's okay. So now, Mirka, can you do it like in a more natural way or not? Like, excellent. And now down. So you see clearly that, of course, we see the different patterns of activities that we have here, but it's clear that it's not, the participant is not doing a strong contraction. And another important part in this section is that the participant learned to relax. As Kate was explaining also in her treatment in the morning, quite common the patients feel like the phantom limb is cramped or the muscles are constantly cramped, and the relaxation part is quite complex for them. So in this stage, we also teach them how to relax, so we can practice both sessions. So once we are happy with our signals, it means that we place the electrode in a correct part. If we don't see that we get muscle activity, it means that we need to change our electrodes. Then we go to the recording session. Can you start? Yes. So here you will see two screens. The one in black will show the movement that, of course, we want to perform, and the other one will show the muscle activity.
Now you rest, and now you plantar flexion.
So we will have
and rest.
We will have 3 repetitions, actually 4. The first one is a dummy one that show which movement we are intending to do, and then we have 3 repetitions with the muscle contraction that we want to do, the movement that we want to perform, and we will do 3 seconds of contraction and 3 seconds of relaxation. So that's why it's quite important that the patient knows how to relax, and that's something that you will train during the sessions. So today we choose just 2 patterns of movements, of course, because we have very good muscles, but normally you start with 1 degree of freedom with your participant. And also another important detail here is that it's important that you show how it works and you guide the patient. Sometimes too much information to actually know what they need to know to do, try to find the movement of the phantom. So it's quite a good training also between the therapist and the participant. So once you finish with the recording session, that we will finish soon, you will get a score. And this score is the one that will let you know if you can move forward with your treatment, in the sense that we will see how the quality of the movement was recorded. Because what happens if we have a bad recording? Then this recording is the one that we are using for the other training stages. So if it's not a good recording, then the patient will get frustrated because he will be not able to perform in all the other stages. Therefore, the recording session is also quite important. I know I'm saying everything is important, but it's true. You need to check everything. Okay, so once we do the recording, how do we know that the recording was good? So can you click in the... No. Here. So here you will see like you have different classifications to see if the recording was poor, adequate, or excellent. So we always try to aim to go to the excellent part of the screen, but of course it takes time. So sometimes some recordings, if you get acceptable, for example, in all your signals, I will suggest to start all over, to do a new recording session. So today is your first session, so it's okay. So we think like, okay, we can use these signals, they're still acceptable, and we have them very good. So we can try, and if not, we do another recording session. So some patients in the beginning, they are not able to move forward in the treatment because it's really hard to do the recording session. But doing the recording session still is part of the training. Again, we are training how to move the phantom and to relax and to train different movements. So it's okay with that. Thanks. So once we are happy with our recording, we can go to the third step of the... We can go to the next step, and it's something that I will show you here. So this is called the virtual reality step, and the idea here is that the participant can control in real time the virtual limb. So Mirka, can I ask you to do up first? And we're doing down. Can you go in? Okay, very good. Now out. Okay, now up. Okay, now down. So for example, when this is quite interesting. Could that happen in life? So for example, now the system recognizes, so we have Mirka's feet, thank God. So we can see that actually how it recognized it was the opposite movement. But the idea is that we actually record the proper movement so the patient can train it both. And yes, so this is one of the VR. We have on time. Yes, so we will stop now to the next presentation, and we will present the other steps with the real patient. If you have questions, we can take it at the end of the session. Thank you very much. Thank you. Thanks.
Thank you very much. Especially Mirka, who was volunteered in an instant way. And also, of course, Maria and Cathrine, and you will see them again in the next presentation. I can imagine you have some questions, but please put your questions in the Slido facility, and the room number is 635252, and we will collect all questions, and we will discuss this later on at the end of this workshop. So now we will move on with the research with the PMI video. PMI stands for Phantom Motor Imagery Treatment. We have now seen the phantom motor execution, where the patient is making actual movements with the phantom. But in the randomized clinical trial, we also used a control group, and the control group got the phantom motor imagery treatment. And we will tell something about the results of the RCT, And for that, it is also nice to have some kind of an idea of how the phantom motor imagery treatment looks like. And that's why Maria and her team made a short video which we would like to show you. So thank you for making this video, Maria. I think it makes a bit clearer what the motor imagery part contains. You saw electrodes on the stump. This is because of the RCT, where we would have the same situations and same setup for both the execution and imagery part of the research. And the electrodes are actually used to control whether the patient contracts his muscles or not. He should not do that, but this is a nice ability to control whether he moves or not. But if you would like to use this as a treatment, it's not necessary to have these electrodes put on. So we will now move on with a second presentation session, and Eva Lendaro, Lotte Hermansson and myself will give this presentation, and I would like to have the first slides, please. As you have already seen in the presentation given by Max Ortiz-Catalan, all the research started with this case study, and we are happy to have this very famous patient in the room, and he will be the patient of the demonstration later on. And you saw that he had weekly sessions, 18 weeks long, and his pain, which was really chronic, changed along the weeks, and the blue lines depict that the pain was reduced considerably, where the red boxes reflect a lot of pain, and you can see that the pain decreased over the weeks. Well, this was a promising result. So the cohort study was performed in 14 patients, and it was published, but the journal also said, well, this cohort study is very nice and promising results. As you have seen, less intrusion in ADL activities or in sleep, less intake of medication, and a retainment of effects after 6 months. But you should actually perform a randomized controlled clinical trial, which was said to the first author, Max Ortiz-Catalan. And so this was executed with a lot of participants. You have seen the list before. And there was also a lower limb case study, which Eva will tell more, and then she will go on with some preliminary results of the RCT.
The next step after the first two preliminary studies, the first two clinical evidence on phantomotor execution, was to implement the technology in the lower limb, and that was done with another case study in which we verified that yes, indeed, the phantomotor execution works for lower limb patients too. And you can see in the upper plot that we have there is the weighted pain distribution, which Professor Ortiz-Catalan explained how to interpret before. And in the bottom plot, you can see the pain rating index, which is an interesting metric that we have used also in the clinical trial as the primary outcome. So you can see, for instance, from the bottom plot that the pain rating has decreased for this patient from the beginning to the end of the treatment by more than 50%, which is what would be considered clinically meaningful. However, like for this patient, for instance, we saw that after, during the follow-up, the pain increased again. And that brings us to the next slide, which is a case series that we have implemented on 4 subjects. We have brought the technology to their home, and we have followed them up for a year. The reason being is because after trying the phantomotor execution treatment, some patients, most of the patients got a good improvement, but then after a while, pains come back after you stop the treatment, and they ask for having this technology home to treat in their daily life. And that was the case for these 4 patients. We had like both upper and lower limbs. And this, here you see the metrics that we looked at. And in this particular subject is the subject, the lower limb subject of the case study. And here you can see the pain rating index. It's about 15, which is what was reached at the end of the treatment, the first trial. And you can see like how the pain, the treatment phantomotor execution was used to manage the pain throughout the home use. It was always more or less about 15 for a year. And here, during this study, we have also looked at something interesting, I think, that is how the patients and the subject adopt the technology in their daily life. And we have, with the help of a medical anthropologist and a human factor researcher, we have looked and tried to define user types. So how, and we have categorized the participants into these 2 user categories. One that is more goal-oriented, so more oriented in achieving like nice scores when training, and another that is more oriented to the experiential use of phantomotor execution, so enjoy more the use of augmented reality, for example. And this is another point that I wanted to make on this slide, is that yeah, it seems that maybe like the pain didn't really go away with this, but when using when following up a case study at home, one should also think that the subject might use the technology when they need it. So pain tracking is a bit different in home setting. And this brings us to the next slide. Here we, as we mentioned many times, we're running this international randomized controlled clinical trial. And it's double-blind. It's a huge effort among many clinics. And we have finally, as we said, a controlled treatment, which has been presented now. And we aim at having 67 patients, 66 patients actually. This was based on power sample calculation on the previous study on 14 patients. And we compare these 2 treatments. And we run 15 sessions. So, and then we have a 3 months follow-up period, three follow-up at 1, 3, and 6 months. And we have finally enrolled all the patients that we needed. Actually, we have enrolled more because the we had more dropouts than what we were expecting. But so we aim at achieving the subject that we had initially planned in order to achieve the power that we were expecting. And now we have completed the treatment of all the enrolled patients. So we have been able to lock the database up to the 15 sessions of the treatment. And today at 14:10, I'm going to present the result of the first 15 sessions.
Thank you, Eva. So we have to wait a bit longer for the preliminary results. I will continue because we not only did some quantitative research, but also qualitative research. So we interviewed patients who contributed to the RCT, to the PME part of the RCT, but also some PMI patients. And the research was performed by Els Keesom from the Netherlands. She's a resident for physical medicine and rehabilitation. And by Kajsa Lidström-Holmqvist from Sweden. They performed actually interviews in Sweden and in the Netherlands. So the aim was to describe the patient experiences from the undergoing the PME treatment. And we had 9 patients in Sweden and 12 patients in the Netherlands with a mean age of 57 years and 16 males. You can see there were a lot of differences in amputations, upper and lower limb amputations, and there were 2 bilaterals. The results of this qualitative study was that most patients felt relief of phantom limb pain, mostly due to getting command over their phantom movements, and also because they were able to relax the phantom limb. They learned to relax the phantom limb, and that gave pain relief as well. Few had no change in their PLP. This is also, of course, interesting, because why do they not have a change in their PLP and others do? As in a few cases, the therapy triggered an increase in PLP, mostly of a short time period. Many of the patients told that the PLP was less intrusive in daily life, which is very important. And some acknowledged that they were allowed to have a phantom, and they had learned to perceive it as a positive feeling. And that was really important for the patients, because it had always been negative, and now they learned that it could also be seen as a positive thing, and that also give relaxation. And some were able to use the exercises at home without applying the PME system. So I have some quotes of this qualitative study. Patients got more energy, which they did not have experience for 20 years or more. They learned they could allow the phantom limb pain. They said it was very positive, it was less bothering their mind. And they gave it a mark of 7.5 instead of 4.5. And there was one PMI patient, and they also got improvement just by watching the videos that you have seen before. For some patients, learning the PME was very confusing, was too much, and then the PMI appeared to be a good alternative. So conclusions of this qualitative part of the patient study was that PME treatment seems a promising addition to existing treatments. There are a lot of treatments, you know. That most patients experience relief because they learn to control or were able to relax the phantom, and they learn to regard their phantom limb sensations as positive. They got a different mindset. So the RCT, the preliminary results, also show promising results of the PME in favor of PMI. But not all patients experience a decrease in phantom limb pain, so we need to search further why this is the case and what are good indications for treatment. And then we thought that not only the patients are interesting to interview, but also the therapists. And Lottie is going to tell you about the therapist study we did.
Thank you, Corry. I think I will need someone to change the slides.
Oh yes, yes.
Yes.
I can do that, yeah.
from a distance. It's hard for me, yeah. So the therapist study, it was conducted by a student of Corry's, Tine van Rietschoten in Groningen, and Monica Pilch, psychologist in Dublin, Ireland, and myself and Corry. And so the aims were to describe therapists' experiences from providing this phantom motor execution treatment, to study the role of therapist-patient bonding, and to see if there are suggestions to improve the PMI treatment, PMI. So 11 therapists who were involved in this treatment from Sweden and the Netherlands were interviewed by Tine. He made online interviews using a semi-structured interview guide in English. So all the participants had to express themselves in English. And the questions about the therapist's experiences of providing this treatment, bonding, and suggestions to improve the treatment. And for the data analysis, we used the same method as with the patient study, which is a framework approach using NVivo software and discussing a framework amongst the researchers before the analysis. So the results. The analysis resulted in 4 themes: the perceived therapeutic effects, the mediating role of the key actors and context, the therapeutic relationship, and potentials inherent in the system and future directions for this treatment. So in the views of the therapists, the phantom motor execution therapeutic effects took place within a complex system of interactions between the key actors, the therapist, the patient, and the device. And this 3-way interaction was identified as an overarching construct, tying the themes together and formed the context for change and an interplay between innovation and intersubjectivity. So, and here are some quotes from this study. Regarding therapeutic alliance, the therapists reported that this was a successful treatment, and a successful treatment is when a patient at the end has some kind of feeling of control over the experience and the feeling of their limb, and is able to be more connected to the feeling. With regards to control, the therapists reported that what they thought, this is a duplication, sorry. So the therapeutic alliance and the control is reported the same, in the same way. The role of a therapist was reported as, and this was also repeated in the interviews, in the citations and in the interviews. Well, you're a therapist, you're a teacher, a personal trainer, supporter, everything, all in one person. So this feeling of having all these roles was reported in different aspects of the treatment. And the expectations and emotions, but again, kind of reassuring them that it's okay if they don't do well, or, so they're not feeling bad about it. And finally, the role of the treatment, it's more effective than mirror therapy in controlling pain, and it gives people more control over what they're doing. So these were quotes from the interviews, and I think you can also see the similarities between the patient's reports and the therapist's reports in the interviews. So the conclusion from this study is that this investigation pointed to factors that should be considered in clinical implementation of this type of innovative rehabilitation treatments and suggest direction for future studies. and the role of an interpersonal context for therapeutic effects and the potential inherent in intersubjectivity are highlighted. And this study is reported more in session tomorrow at 1:30 to 2 by one of the co-authors, Monica Pilch. So thank you. And now we will move on to the next point in the schedule in this workshop. And now Maria Munoz and Cathrine Widehammar will demonstrate the therapy in a patient with an upper limb amputation.
Hi again. So now we have a very important visitor this day. Like, we're quite happy that you're here. We have Ture. So as Corry was saying before, and Max as well, he was our first participant in all this journey. So that's why we're quite happy. Thank you very much for joining today. So Ture had an amputation in 1965, so quite a long time ago. It was a traumatic by a traumatic cause because of a car accident. And when he came to Max, the main problem that he was presenting, it was phantom limb pain, that if I recall correctly, it was actually limiting him a lot, his daily life activities, his quality of life. So here is when we start actually all the story. So, okay, let me, yes.
Of course, you're number one.
You're number one. I can help you. But yeah, so with the difference that we have between upper and lower limb, of course, both have the same principle with the electrode placement. We follow like the same baseline, but of course the treatment is quite different. And also something interesting that we have seen with our patients is that the difference is that sometimes lower limbs take a little bit longer to actually get resolved with our participants. And that is something that also Max talked yesterday in his talk. We think, like, of course, the homunculus of the hand is quite larger in compared with the lower limb. So we have normally sometimes this protocol of 15 sessions, and sometimes with a lower limb we take a little bit more sessions to actually see some results. Okay, so are we in... okay, I will load the data. Yes. So we already pre-record certain movements with with Ture. So today we are going to do elbow, flex and extend elbow, and open and close hand. And if we have time, we also want to show you how he controlled the little finger, actually that he can still feel the movement of the little finger. Yes.
What is this?
I help you. Here. Okay. Yes, it's okay. Okay.
So, should we start with the photo?
If you want.
And now you can move your arm in different directions, and we can see what you are doing.
So we can start maybe exactly with open hand. Yes.
And close.
Now you can flex your elbow, please. And now extend. So actually, so Ture, as we were talking before, he has the system at home, so he actually is in a high level, and he have had a lot of sessions, so he is quite good. So actually with him we can move forward to simultaneous movement, and also you can actually see a little bit here, but you can also, because we want him to challenge, we probably can do much harder movements and try actually distal movements as fingers. Something interesting that we have seen also, this is mainly in practice, like many times, because we need to give the patient challenge, fingers or toes is quite hard for them to find and to try to do the movement. But we have seen, like, if you go since the beginning to the distal movements, you will still see quite a good effect. So That's why we don't need to be afraid is in the beginning the patient is not able to recall or to find the movement. So it's good to go further.
And Ture told us earlier that you had your phantom pain in the little finger and the finger beside. And when you have practiced a lot with the little finger, the pain disappeared for a while in the little finger.
Yes, and only 2 or 3 days ago, I tried very hard. So just one day I had no pain at all in the little finger. But normally is it in the little finger top and the ring finger top. And because how much it's from day to day, more sometimes when I have worked very hard with the prosthesis, all the finger is I have pain in all the finger, but now when I have pain nowadays, it's such a very short. It's about some seconds, but when I begin with this treatments, I have a little pain all the time, and more pain, and it was like you said in the under down of the
more parts of the hand.
In the hand, yeah.
So
and it takes minutes, and it was and it's. But when I began with this, just in the first 2 days, it was worse, and they asked me if I wanted to go on, and then I'll say yes, we must go on. Something happens.
yeah.
So because I am so very newsly. So I must go on and see what happened, and after a while, the pain bent down and was shorter and shorter, and then after some weeks, on the after they asked me after why. Every treatment, they interview me and wonder how you feel, and I said that I think it's something is I don't know, I can't describe it, and they asked me, have you more pain? Or I think, no, I have no pain at all.
And that's great. I think we have to show them some of your exercises now, but it's wonderful to listen to your stories.
Yeah, and actually it's quite interesting that Ture tell that, because it's quite common that in the beginning, when we start with the patients, in the first sessions, you can have this increase of pain. That we have seen it many times, and we tell them like, hey, this could happen, so don't be afraid, because it's a common behavior that we have seen. Like, imagine they haven't used this nervous circuit or all this muscle contraction for a while, so reactivating all this, of course, it can entail maybe some pain. So that's something, that behavior that we have seen.
Should we start?
Yes.
The next?
Yeah, so moving to the next step. So we start
this one? Or was it?
Yes.
The tag?
Yes,
test?
we can do the tag test. So another step that we have is the tag test, achievement control, on which we will see 2 virtual limbs, and the idea is that the participant in real time is in control of the grain arm. So once they get in the position, they need to So for example, now it was too much, yes, and relax. So once they match the position, the participant need to relax. So he had very good control, so as you can see, he's able to easily match the position. But of course, if there is more muscle contraction, then the target is not achieved.
No.
This good. Jättebra. This actually part many patients like it very much because it's also it demands a lot of attention because here you see it's like super nice, a smoothie, but it's not the case. Unfortunately, we don't have the time to challenge you to come and try it, but maybe next conference. But it's actually quite hard to be able to control your muscles. And another tricky part is to relax. So that's why if the patient arrive to the target and if it keeps contracting, that's why they go over the position. So that's why relaxation is also a really important stage. So it's random positions according to the movement that we select, and at the end you will see a final score that is a percentage of how was the performance of the patient. So it's a good indication for you to say like, okay, the participant is able to manage these movements. Maybe we can go one step farther. So we can challenge him doing simultaneous movement, for example, or finger, as we said before. So as you will see, 100%, very good. An applause please for Tori. Very good. We have a very good one patient here. So this is an indication, okay, maybe we can go to the next step easily. So this is one, yes. Maybe if you want, you. Oh, okay, I can explain. So we have another step is called augmented reality, on which we place. So he is a pro, as you see. He normally trains at home, so he actually put it by himself. So it's a marker, a fiducial marker, on which you need a computer with a webcam, and the idea. I think I will move you a little bit backwards. Yes.
Oh, should we take a chair? Huh? That's okay.
Let's see. Excellent. There you go.
Little.
Yes. So as you see, then augmented reality and an arm will appear in the screen, and the idea is that here the patient can practice also with this augmented reality. Yes.
And if it's hard to find the movement, you can tell the patient to use the other arm to do it simultaneously. So, but you don't have any problem finding it. You can.
So it's quite interesting. Like in the beginning, some participants love this stage because it's quite fascinating. It's like, wow. So I have some patients that actually have cried when we arrive to this stage because it's quite like visual. It's quite strong to see that you finally have an arm and you are in real time controlling. So it could be quite a nice experience. And here we leave them explore and try different movements. But in certain patients, actually, it's quite strong to see it. So they just prefer to avoid this step because it is like affect their body image. So there's not a rule of all the sessions that you or the steps that you need to do. Just if you try to promote phantomotor execution is good enough. How does it feel?
I think this is Ture's favorite training. You like this the most. This part you like the most. Is the best.
Yes, it's because I like this.
You like to see yourself.
And it's so naturally as I sometimes if I had a table here, I will see so that I not clock came down to the table.
Yeah, that's perfect, and that's important. Like if you try this system with your patients, it's very important that you have like a nice space and area to actually be able to move all. You see all the range of motion of
move it out too. No, it doesn't follow. Something wrong.
It's for because we are online, so
Okay.
sometimes happen. So yeah, this is another of the sections that we have in our treatment. You can see.
Sorry.
It's okay. And we have the last part of our treatment is also a game. So the idea is that with the movement that we record, the patient can control a card game, a Tetris, and there are we have included in our system 2 games, but of course there are other online computers games that we can use. Now for the demonstration, we will use the ones of the software. But this one is also quite a challenging step. So, for example, which are the movements that we use for left and right?
I don't really remember. I think it was the elbow. Is it the elbow? Or is it the hand?
So you're controlling the computer as well.
What are you doing? The elbow? Or is it the hand?
So you see, he's having control of all my computers, so he's changing the levels as well. That was not in the plan. So how we can check that he have the control of the computer? I will just stop this one, 2 seconds. So in the software here you have in settings. I will stop this one. So the idea is that you remember here we have the movements that we record, and also here you have the different movements that you can select the different directions where you want to control the game. So I will just remove. Wait. I will remove this one because if not, he will have control of my computer. I don't want that this time. Okay, so now we are going to use left and right with open and closed hand. Yes, is that okay? Yes. So now that we are set, we can go to.
Vänster.
We turn and okay. So here we have the breakout. We will put the first level. So as you see, it's time that he open and close the paddle moves. So let's see and let's try to kill as much blocks as possible.
But this was new for Ture.
Oh,
he hasn't tried this game before.
Yeah.
You used to drive the car.
So now, and relax. Go. Good. Yes. Excellent. So the idea is that here in the game, you can keep challenging the participant to try to reach different stages and promote different movements. So for example, when you are with a patient, you can say, hey, let's try to kill all the pink, or you can put different goals to keep them moving through. It's also happened that sometimes they get distracted and it's quite hard to manage. Also, we can show the card game because he also have control of the 4 directions. So now we will see with the card game how he can also perform this. So we need to select stop.
Couldn't do the card?
Yeah, no, not directly.
Okay.
Yes. So we go to setting and we select flex and extend as well.
Oh, you like to have those?
So when we do the card game, some patients also love this stage because it's goal oriented and they need to reach something. Of course, everyone have different personalities, so you need to adapt to them. But it's quite nice because you create this complicity also that we can do it. And there was a patient who was quite nice because he was not able to perform the movements when we were in the other stages. But because it was challenging, he was able to flex and extend the elbow for the first time. So you really need to see what's the best way. So we will put a final here. So can you please first? Yes, exactly. And now can you break? And you stop? Exactly. So now we are controlling.
What happened?
We open here. Don't worry. So now it's time that to the flex, the car accelerates, and if he extends, the car brakes. Now can you open? Oh, you're going super fast. So
you drive too fast.
Yeah. Piano. Then now, for example, if you close your hand, excellent. So we close and we go back to the row, excellent. So now you see that the patient can control the direction and the accelerate and brake at the same time. this game is a little bit simple, but of course we have others that are more complex, like Trackmania or open source games that you can also try with the game. Yes. Excellent.
Could you stop the car?
Yeah. Excellent. Great. So, how are we with the time? Do we have?
I think it's
almost the time. Yeah. Okay. So, but well, these are the four. Those are all the stages that we have with the treatment. The idea is, in a session, you can do all these steps with different movements. So, as I explained you before, we have like 2 hours of treatment normally. So you can start with a pair of movement, then we many times do a break because it's quite exhausted for the patient to be able to perform the different movements. And then we continue and do something more hard. So again, we aim is to promote phantom motor execution while we are challenged and doing like mindfully repetition with all the different stages. So that's mainly, unless, sorry, if you want to add something else.
No, I think you have told everything.
Okay, so that's mainly, I will give that space to Corry. Thank you very much.
Well, thank you very much. First place tour, I would like to have an applause for his participation. And also Maria and Cathrine for giving this demonstration. In the meantime, there have been some questions posted. Oh, you can have this mic. And Jan will read them aloud so we can see if we can answer these questions. So Maria and Cathrine, can you come to the front so you can also assist in answering the questions? And Lottie is online. Maybe, yeah, if there are questions for Max and Eva, maybe you want to come to the front as well.
So I'm going to start with the first question we got here. And the question is, how available is the technology for this treatment to this day? Cost and all the other things included.
Maria, is that a question for you to answer or maybe for Max?
Yeah, I can answer that. Here or here?
I hear you talking through the mic. So
Okay. So this product is marked by Integrum currently. We are now is only available for clinics and clinicians. Unfortunately, we are not in the step that we can give it for patients. And of course, we have a range of price, but also we have some adaptation according to the different countries. Yeah, so that's mainly, but of course we are trying, the dream is to make this technology available for as many patients as possible, but it has been a journey. But there are ways if patients want to get access to treatment. We have different centers in different parts of the world, so they can contact us and we can address them to different centers if that is needed.
Thank you very much. The next question is, what is the difference between the last part of PMI and PME as the patient can control the avatar?
You can also, Cathrine can answer.
Well, the difference is that in the PME you don't use the muscles and you don't do any muscle execution, I would say.
Yeah, I don't know if it was clear in the video, but in the PMI, the patient was controlling the game with the keyboard. So the idea is not that it was automatic control.
Okay.
Yeah, so that's the main difference.
Thank you. And another question is, do you think the use of phantom motor execution in the early stage post-amputation could be utilized as a preventative measure for phantom limb pain?
If you name it. There is a group in Australia that is been using it for preventing phantom limb pain just after the amputation, but that has not been run as a proper clinical trial. So at this point, you can say it's anecdotal evidence, but theoretically, yes. I mean, it would be ideally actually that you start using it before phantom limb pain even takes place as a prophylactic.
On the other hand, from my own clinical experience, we do not do that because the therapy is quite intensive, so you need a lot of time from the therapist, and so it's quite a costly procedure. in that sense, and we'd first try this more simple methods, like mirror therapy, for example, and if that doesn't, and medication, or we use EMDR or whatever, and if that does not work, then we apply the PME treatment. But maybe the therapy can be shorter in the acute phase, and then it will become cheaper, so that might be an option. But there are also practical reasons for postponing it a bit.
Right. There is a cost time of therapies apply, and I suppose it also depends on the evidence. So something we haven't done because we thought there was not much sense to do is to compare this with standard mirror therapy, just because we wanted to have a clinical trial where we're comparing the execution and the imagination. But in principle, if you want to be evidence-based, something that could be done is do PME versus mirror therapy, and then see at these results. And if you want to treat patients based on evidence, then you could decide which treatment should be done first. But then if you look at the cost, that's a different matter.
Yeah, but it also counts. And in that respect, the option of giving home treatments is very interesting, because that takes less therapist time, and it might be an option for the acute phase. So teach the patient how to do it, give it the system to the homes, and then only return a few times to the clinic, and that might be an option as well.
One aspect that came through in the therapy interviews and also in the patient interviews is the time also for the patients. Time away from work, time for travel and such things. So I think the home treatment is a good option. Once you can treat the patients first and show them how to do it, then they can continue at home. Yeah.
Any other questions?
Yes. We have a viewer wondering that if you have a flare-up again, do you need to use the equipment again, or since they now have learned to execute certain movements, don't they need the equipment anymore?
That's maybe a question for Ture. I don't know if he followed, but so he has said that after he learned to do the phantom movements, he feels pain. Sometimes he can get rid of it just by doing the phantom movements, but of course it helps, and I think that's something we have here repeatedly for many patients.
Yeah, some patients can apply the system without using the system. Not all people can do that. In our practice, we had some people returning to our clinic and asking for some kind of a repeating of the treatment, and then we give a shorter treatment and they can move ahead. But I don't know what your experiences are in that sense.
Yeah, for me it's similar, and actually while we are doing the treatment, we suggest the participant, like, hey, try also when you are at home, try to feel the movement and try to practice, so then it's also easier for them for later on. But yeah, I have a patient that she referred that mainly when the peak of pain was coming, like in just the moment, if she started doing the phantom, it was like very nice to decrease the pain. So for sure, yeah.
We have similar experiences from our clinic. Yes.
Yeah. And also for this, the home system would be nice, because these patients are all experienced and you don't have to explain anything anymore, and you can give them the home system and they return it after 6 or 8 weeks, and then another patient can have the home system.
So we have one of the RCT patients who dropped out from the study. He also commented that now I've learned this and I can do this. I don't have to travel. I can do this myself at home to relieve the pain. Yeah.
Not great for the study, but great for the patient.
Yeah.
Yes. But also it's a comment on this time-consuming part of being in the therapy.
There's room for one more question.
Okay, and then I'm picking one of a prostheticist that has observed during his clinical practice that if people with amputation use a myoelectric prosthesis, that both tingling sensation decrease and also, well, in general, maybe also phantom limb pain reported decreases. And that person is wondering, are there any studies going on studying how myoelectric use in this case, in prosthetics, affects phantom limb pain?
There have been studies. Professor Floor's group have published that prosthetic use reduces phantom limb pain if it's an active prosthesis. I'm not sure if the guys at Co-opt are doing that. I think they are actually doing something like that. So and that will be related to the execution of movement and trying to do the movement. However, the prosthesis can only give you so much when it comes to degrees of freedom. So most prostheses will be 1 degree of freedom, the hand open and closes, and then if you have a multi-articulated hand, maybe you have a little bit more. But otherwise, you cannot do all the movements. Whether in virtual reality, then you can do like flexion extension of the hand, for instance. No commercially available prostheses do that, and simultaneous movements and things like that. So the advantage with virtual reality is that it allows you to do movements that you cannot do in your prosthesis. And I will say, just to close my comment here, the reports that we hear for patients that they get rid of their phantom limb pain by doing phantom movements is, again, what I say is it's evidence against this idea of sensory motor incongruence, because otherwise those patients will be having more pain because they are trying to do movements and they don't have sensory feedback.
Thank you. So our time is up, so I would like to close this workshop. And I would like to thank everybody that contributed to this workshop, in particular Tore Johansson and Mirka Buist. And I would like to invite you all to this afternoon's session, where Eva Lendaro will speak and where Kajsa Lidström will speak. And tomorrow there's the poster session of Monica Pielch, where you can listen and look at all the results in more detail. And I would say enjoy your lunch. And we will be back at 1:30.